Thank you, Sensei, for your wonderful presentation. Each case you have shown is itself a learning lesson. All cases are wonderful with lot of concepts you have shown. Your biological compression concept for with use of bulky flaps in case of avium, use of the ninth intercostal perforator for the long flaps, and the use of 5 centimeter anterior of the LD only inclusion in case of the tap flap. Also, your concept of jackknife concept in cases where you want to harvest long flap is all amazing concepts. Each case is wonderful. Sensei, we have a huge list of questions for you in the box. I think Dr. Valerie wants to ask questions to both of the presenters. I think you can go ahead, Valerie.
Um, okay. Well, actually, I think Sensei's presentation is so inspiring and a very impressive, amazing aesthetic result. So for the AVM, yeah, so I understand that embolization actually maybe will burn away the potential recipient vessels. So for that particular patient, what vessels was used in the end?
You mean the AVM?
The AVM, that the 12-year-old patient.
Yeah, usually
Because I remember the angiogram was very diffuse, very extensive.
Usually all the artery become bigger. Almost all AVM patient recipient vessel is very big. So into-side anastomsis is very nice. Arterial inflow is very nice, but the problem is the venous drainage. Always recipient vessel has a higher pressure. So that's why usually distal flap necrosis many times occurs. But total necrosis is not so many. Distal necrosis many times occurs. So we use important point to get wide survival is post-operative higher position. Skeletal suspension. So you should use a pin to fix the tibia and hold up the leg. Maybe if possible 1 week. So higher venous pressure decrease and the survival ranks increase. If possible, you should use metal suspension, metal frame. Ask orthopedic surgeons so they'll support metal frame, metal suspension. I use a very convenient method to use a rope suspension from the higher area. So patients have some problem, but ask the patient to tolerate this higher positional, higher
For how
position
long?
post-operative.
For how long?
1 week.
Oh, okay.
Or three days a little bit short. Yeah. But anyway, free flap is sometimes difficult, very severe. It depends on the severity of needles. If a needles is very big area, only one case I lost even a pedicle growing flap. 1 month I wait. This defect big area. So, but I put the pedicle growing flap 4 weeks and transect, but all growing flap are necrotized after transections. But only one case. So depend on the needles. Yeah.
Yes.
Upon maybe preoperative embolization, maybe okay, probably okay, but lower leg, very dangerous. Upon, but if possible, better not to do preoperative embolization, even upon.
Yeah,
because
because
we can use a tourniquet. Yeah, 1.5 hours, it's okay.
Mhm.
Sometimes 2 hours. Yeah, post-operative, sensory loss continue the 1 week. But
Mhm.
I never, have, permanent, nerve palsy.
Mhm.
2 hour or 2.5 hours maybe okay, but if possible, 1.5 hours. So within the 1.5 hours, you should sacrifice, reject almost all needles. So this is
Yes.
very important. Use preoperative planning is very very important.
Yeah.
Short time, wide resection. So
Mm.
you use only you. It's very difficult. So where experienced assistant is necessary. Remove short time removal of AVM.
Mm.
Always ligate and reject. Ligation, simultaneous ligation is very, very important. If you don't do this ligation, massive bleeding occurs after release tourniquet. Also, professional use of tourniquet, temporary,
Mm.
short-time
Tourniquet.
release of tourniquet
Tourniquet.
with high compression with tie, and
Mm.
and also,
Mm.
massive bleeding always occurs after releasing a tourniquet. So, extensive ligation with a
Yes.
very fast speed ligation is
Yes.
very important
Thank you,
for,
Sensei.
yeah.
Yes. Yeah. Just a quick question to Dr. Wen, because I know your team will have a meeting after this Zoom meeting. Jing Jing?
Dr.
Jing
Wen
Jing?
is now escape.
I think there is a trouble in the internet there, Sensei.
Okay.
But before
Uh,
that, Newman has a question.
Yeah.
okay, okay.
Thank you. That's a very, very impressive presentation, from Cosima. So my question is regarding the muscle component on the TAP flap.
Yeah.
For example, in the case of osteomyelitis, if we add some muscle component into the osteomyelitis area, will help the healing process or not, or just enough the vascularized bone and skin component only. Thank you for your advice.
Yeah. You're asking the volume of muscle?
No, I mean, we know that the muscle has a very good vascular supply,
Yeah.
vascularization compared to the maybe skin or fascia. So
Mhm.
in the osteomyelitis area where the infection is maybe uh, very severe there, if we give a muscle component, the blood supply to that area maybe will be better and the healing
Yeah.
process will be improved. What do you think?
Yeah, infection area. For example, osteomyelitis. Yeah, everyone believe muscle are essential, but I don't think thick muscle are not necessary. Very thin muscle is okay. Also, I always change the muscle volume in each patient because lateral descent branch of within the muscle, every muscle is depend on the case, different area, different position. Some case descent branch is only the margin of the muscle. Some case little medial side. So that's why I always confirm the position of the descending branch and decide the volume of the including muscle. Only production portion, descending branch, not so long. Only production portion that descending branch should be included. So big flap, long flap survive. So this is the depend on the anatomical position of the lateral descending branch and control the volume of LD muscle. Only proximal region is enough. This is a very important point. No need to include heavy volume, even osteomyelitis, rather than the muscle vascular bone. Well, vascular bone is more important. Muscle is not so important.
Yeah, thank you so much for.
Yeah, welcome. Important point.
Sensei, regarding this AVM, Dr. Reiko has a question. How much percentage of AVM cases where you have not done pre-operatively embolization, you can salvage using flap reconstruction and avoid amputation? And how much part of the AVM do you resect? Do you totally resect the AVM radically or do you do a partial resection?
Yeah, as much as possible. Almost all needles should be sacrificed, but maybe 20% still remain. Even if we reject the maximum power reject, but maybe 20% still remain. Cannot reject 100%. So remaining 20% many times expand with thin flap coverage or with skin graft. The expansion, always the expansion occurs. But thick flap, the expansion very rare, no occur for long hours. So gradual decrease of adipose tissue. It's safe. I learned from this concept is learned from Professor Malikan. Malikan is a pioneer of AVM surgery. Harvard medical. Probably he's still operating. Now he's over 80. Crazy guy, real crazy guy. Specialized AVM. I learned 1 year under him. So he always think thick flap are necessary to prevent the re-expansion of the AVM. So I came back and doing 30 years after I came back from Harvard. So this is the truth. I tried many AVM, very severe case. So now, Chin came back.
Yes, Dr. Wen is online again.
No,
Yes,
it's,
I come back. Sorry.
I'm happy to see you. Yeah, so
Yes.
for is a question about Alzheimer's surgery. Yeah, so actually I realized your center should have several or more patients that has been operated. But
Yes.
in the paper actually only one patient, so I'm interested to know how about the other patients in general, and so far what's the longest period of follow-up?
Yes. Actually, we just write the first case because we use this method to do the Alzheimer's disease. I think this is the first one to report this way, so we think it's important to publish as soon as possible. So we choose to publish one case, but actually we totally finish almost 40%, and we the first patient from last year's maybe December, we do the first one, and from now on, the follow-up maybe not 1 year is enough, but the results are more than maybe 80% persons is good. Yeah, we are writing the second and the third papers about this. It's about the Alzheimer's disease case series. So maybe we will publish later and I will share more information with you.
Thank you. And how about the operative time? How about the operative time on average?
Yes, we choose the conservative methods, maybe more than six months. If no change, we
No,
choose
I
to
mean
do the surgery.
operation
medicine.
hours. The hours for the
Operation
operation.
hours.
Oh.
Well, we use the wing graft maybe more than 6 hours.
But
Yeah.
do you think there's a possibility in case the vein graft, maybe if the vein graft to the EJV, in case there's a blockage, then all the LVA above will be become not useful anymore. Once there's a obstruction at one site, and then all the upstream points may have risk of obstruction as well, maybe. Yeah, that's what I
Yes.
worry about. Yeah, and thinking, because I understand your concept is very nice, but yeah, maybe you have more experience to share.
Yes, yes. It's possible, but we check the wing graft patencies by ultrasounds. Just see no blood inside, but we can see the make 100% sure about the lymphatic vessels can get completely success, but no embryosis inside. It's sure. But maybe your question is the key point. Yeah, we need to pay more attention about this part, and maybe we will answer you later.
Yes, I do look forward in China, this surgery can be resumed as soon as possible, and so as more
Yes.
evidence can be, we can see more evidence. Yeah, thank you so much.
Yes.
Yeah,
Thank you.
thank you.
Sensei, we have list of questions for you. I'll go one by one. In jumping flap concepts, how do you avoid the pedicle exposure in between desiccation of this? Do you put any graft or any collagen dressings? And when do you divide this pedicle in jumping flaps?
Yeah. It's raw area will cover with wet dressing, ointment, and sponge, and maybe 2 weeks or 3 weeks enough. But the recipient side has ischemic area. In that case, wait maybe 3 weeks. But with partial recipient, maybe 10 days. 10 days, okay.
Okay.
Yeah.
Next question is, how do you choose the recipient vessel in cases of AVM or lymphatic malformation especially? And do you do any special investigations pre-operatively to choose a vessel in this cases of AVM malformations?
Lymphatic malformation usually, artery and veins are normal.
Okay.
So I also preoperative echo. We can see, check the many small artery perforator. So main recipient always exists, and also additional perforator. I always prepare and anastomos as many as possible, not single, because double or triple anastomosis using end-to side technique, we can make several anastomosis using a single artery or vein. Use end-to side technique. So even a flap has only one artery and vein, a recipient only one artery and vein. In that case, we can make several anastomosis in each artery and vein. Use a Y-shape or H-shape vein graft from dorsal foot. Oh, this is a very nice technique. So if during surgery, you feel some problem or fear of post-operative obstruction, in that case, use a vein graft and increase the number of anastomosis. So this prevents nighttime exploration. How to decrease nighttime exploration? This is very important. So yeah, operator always pay attention because the young generation never follow us. Operation is frequent. In that case, young generation never want to do microsurgery. So always one stage successful result. Many young generation want to do. It's also aesthetic reconstruction is more important because young female and beautiful leg reconstruction or hand reconstruction. This is very attractive, especially woman microsurgeon. So nowadays, today also, woman young microsurgeon are increasing and discuss the lymphatic surgery and also Alzheimer. This is amazing. Probably in future, woman microsurgeon increase and control all over the world, rather than male microsurgeon. I believe.
Yes, Sensei. Thank you,
Yeah.
Sensei. Thank you
You
for your
also.
encouraging
Yeah.
words, Sensei. So, Sensei, when you take a long flap, so you supercharge these flaps. When you take a very long flap, the distal end, do you supercharge always with the perforator?
Yeah, this is also very important point. Yeah, if you want to over 40 centimeter, you must supercharge distal or proximal. So combine tap and skip. Yeah, last week I demonstrate this flap is the best. Also, ALT combined with skip. And also today I show you DIP combined with a skip. We can choose many combination. Also ALT TFL combined with ALT or combined with saphenous strap. This also take a very long wrap. So this is also we can enjoy this combination. But supercharged recipient vessel is not so many. Nice vessel exists, so that's why preoperative echo. We must prepare the several perforator, muscle perforator or intermuscular perforator with Doppler. Always prepare the many recipient perforator. So perforator to perforator anastomsis is very important from now. Supercharge. Yeah.
Sensei, your concept of nerve bypass was also fantastic using saphenous to posterior tibial nerve flaps.
Yeah.
In these cases, postoperatively, how do you follow them up? Do you use any specific physiotherapy or footwear for these cases, Sensei?
No. I never do.
Okay.
So spontaneous recovery occur. But today's case is already 50 years past. So now become a little bit fibrotic. So that's why nerve sprouting is not so good. But early stage is still fibrosis is not so sick. So those cases showed a very nice result because both nerve trunk has well vascularized. So vascularization is very important.
Sensei. Sensei, people want to know about your jackknife concept. Where exactly do you use this concept of jackknife? What cases do you use? What kind of defects do you use this?
Yeah, children or young female, we should take a short donor scar. So in that case, little bit wide, maximum width maybe 8 centimeter, and split split the from proximal to distal. Distal portion. We always check the perforator, subdermal perforator. So if distal portion, the subdermal perforator existed, in that case, we can divide the flap like this.
Yeah.
So like this. So it 2 times longer. Incision is short, maybe 10 centimeter. So with jackknife, the length become 20 centimeter in length. So this is very useful, especially in the anterior, mid-axial region. Several capillary perforator exist, so that's why even jackknife, incision, flap never necrotize. Also, radial forearm is also. I try many flap with the jackknife incision. So radial forearm also extend as a jackknife. And also skip flap. Skipper is also best. Distal portion. Flap on. This is the flap on flap concept. Distal perforator has a very big power. So we can make this extension with distal perforator preservation. Also sometimes a triple extension. This split and the extension concept is useful not only the flap, but more important, extension is nerve trunk. Nerve trunk has many fascicles, so also fascicles should be separated with the distal preservation. So Barcia's nerve flap, only 5 centimeter, 5 centimeter nerve flap could be turned to extend the distal side with the distal vascular preservation. This micro vascular supply within nerve trunk. Nerve trunk has a rich vascular system. That's why nerve extension, jackknife extension, vascular extension is possible. Many tissue, even adipose tissue or fascia, short lengths become longer. Not only double extension, triple extension, vascular nerve, triple extension is also possible. I succeeded, triple extension. So we need no more long nerve graft, nerve flap. Short nerve is enough. 3 times extension. This is a very interesting concept. You can enjoy this jackknife concept.
Yes, Sensei. I think Sachin, do you have any questions?
I don't have any questions. It's all already asked. Questions are asked, and I would like to invite if Dr. Hiro Hiramatsu Sensei is there.
Okay.
If he's there today.
I don't see him.
Hiramatsu Sensei is
Okay, he's not.
No, he's not
Not
logged
here,
in.
no.
Yeah.
Dr. Newman has any questions? Okay.
No, that's enough already.
Okay.
Yes.
Okay.
Already you are enjoying.
Yeah.
Enjoying the
I don't
concept.
see any more questions in the chat box. If anyone has to have any comments, please go ahead. Otherwise, we'll proceed with our group photo.
Yes.
Yeah. So I request everyone to please turn on their cameras to have a group photo. On the count of 3. Yeah, everyone please turn on their photographs. 1, 2, 3. Yeah, one more tick. 1, 2, 3. Thank you, everyone. Thank you for the wonderful
Yeah.
session.
Yeah,
And I
2
really
weeks.
thank both
Yeah.
the
Next
speakers.
2 weeks, I have a schedule. So next 2 weeks, I cannot present
Yes.
story. Yeah.
Yeah. Thank you, everyone. Thank you, Sensei. Thank you,
Okay.
Dr.
Thank you.
You.
for your wonderful
Thank you.
presentations. And thank you, all of you, for participating in this session and making it live. Thank you.
See you.
Thank you.
See you.
See you, Sensei. Thank you.
Bye
Thank you.
bye.
Thank you. Bye-bye.
Bye.
Bye, Jing Jing. Bye-bye.
Bye.
Bye bye.
Bye, Anirudh.
Bye.
Yes,
Thank
bye-bye.
you. Bye bye.